Sheila and go forward here with what we were talking about yesterday. Okay, Sheila, I think you were looking at this case and you said that there's some abnormal signal here at the base of the anterior labrum, and we're just getting to this. And here's the ABER view, where we can actually see now that there is a separation here at the base of the anterior labrum with thickening of the periosteal attachment in that location. And this just shows how occasionally you can really see the labral tears better in the ABER view. In a study of about 200 patients that we did a number of years ago, we actually found that this was pretty rare. We could only see this in about 1 or 2%, about 1%, I think, of the patients. We only had about 2 or 3 patients in 200 where we actually saw this occurring. So I stopped doing this routinely just for labral tears. As I talked about before, I really like the ABER position primarily now in young overhead athletes looking more for posterior impingement. Here's an anterior labral tear, which we can see without contrast in the joint space. Obviously, lack of communication of the nice black signal, increased signal intensity at the base of the anterior labrum. ABER view, which really wasn't all that helpful, kind of showed the abnormal signal intensity. Now looking at signal intensity within the labrum, just remember that at the base here, this is actually cortical bone, or the subchondral bone, not cortical bone, subchondral bone. On top of the subchondral bone is a layer of cartilage which can undermine the labrum itself. And then the labrum on top of that, again, this is a nice gentle curve. The signal intensity within the articular cartilage here varies tremendously from being black so that you can't even see it to brighter where you can see it like this, but that kind of a configuration is normal. Tears, however, you shouldn't have any cartilage out in the substance of the triangle itself. So again, increased signal intensity within the triangle of the labrum is one of the better findings that we have for labral tears. Here's another patient here where we can see the articular cartilage here, labrum, and there are kind of 2 lines. The second line is a labral tear. The first thick line down here is articular cartilage. So again, we're seeing signal that's definitely within the labrum, not at the base of the labrum. And also, the cartilage goes parallel to the bone. Tears can also be perpendicular like this, especially if they're associated with anterior dislocations, where when you anterior dislocate it, the humeral head goes over the bony prominence of the anterior inferior glenoid and shears off the labrum just like a shears. So, and those tears tend to be more in this direction, which no normal signal should be in. So those are different kinds of tears. Yes?
On the bottom right-hand corner, then that little triangle that's more medially, is that labrum then too?
This is labrum right here.
And is that displaced, or is that just a normal?
No, I think that's the normal labrum. We're kind of partial voluming it at the inferior margin here. This is anterior inferiorly, and we're getting a little bit of the inferior labrum in that particular cut because of the thickness of the cut, and that's been a shearing injury in a patient who had a dislocation.
Okay, thank you.
Yeah, a Bankart type tear. Now, well, let's talk a little bit about the osseous anatomy because it's something that can certainly contribute to instability. The normal humeral head has a retroversion of about 20 to 30 degrees. And see a radius like that. The main thing here is the glenoid. A lot of people say the glenoid is like a tee when you're teeing up a ball for the golfers in the crowd. And this is the ball. And therefore, the tee is small here in this particular case, so inherently it's unstable. So the bony anatomy is unstable. It's not a big, deep socket like, say, the hip joint is typically. And therefore, the soft tissues are very important for stabilizing the shoulder. And the reason it has this bony configuration is that the shoulder has the largest range of motion of any joint in the body. In order to have that range of motion, you can't have bone get in the way. So it's intrinsically unstable. Now, something that you really need to eyeball every time you look at an MR scan is the version of the glenoid. And this is an abnormal case. This would be a dysplasia of the glenoid, where if you draw a line along the long axis of the scapula, and I'll show examples of this in a minute. Uh, line along the glenoid, we would find that instead of being a 90-degree angle here, this is the face of the glenoid is going to be retroverted abnormally, and this would lead to increased risk for posterior instability. And I'll show you how you measure that in a minute. So typically, glenoid version, about 70% has a little bit of retroversion, which is normal, but greater than about 8 to 10% would be abnormal. That's 10% from the 90-degree angle there. You can have anteversion, but with anteversion, then you have an increased association with anterior dislocations. So here's just an example on a CT scan of how you can measure the version angle. And this angle should be 90 degrees. In this case, it's 50 degrees. So in this particular case, you would have 40 degrees of retroversion. And this is obviously abnormal. They're obviously going to be at risk for posterior displacement, and we can see a lot of bony abnormalities in this individual who has probably had displacements with bone injuries associated with it. Here's another example where there's really just poor development of the posterior lip of the glenoid. This isn't a rare condition. It's not common, but it's rare. And typically when you have poor development of the posterior glenoid or this severe retroversion of the glenoid, you'll have a very large posterior labrum like we're seeing here. But that labrum, and certainly the labral bony junction, really doesn't have the same strength as bone does there. So it's very easy and it's very common to get tears of the posterior labrum in this situation, which lead to posterior instability. So this is a cause of posterior instability. You just have to eyeball every case. It's not that common, but you will see it this year, and it's a very important risk. And some people call this congenital instability. This is a paper from IGHL where they graded different degrees of underdevelopment of the posterior glenoid, and typically the more they underdevelop the bone, the larger the posterior labrum, and the greater the risk for posterior instability and posterior labral tears. Here's just another example of a 25-year-old male with chronic instability. You can see a very poor developed glenoid in this location. The posterior limb is really very smooth, and you can see this patient was imaged in a position of posterior dislocation of the humeral head. And this is all due to congenital dysplasia. Just some x-ray findings of congenital dysplasia. In this particular case, you can see very abnormal development or lack of development of the glenoid, a lot of effusion here, a lot of degenerative diseases of the humeral head, and this patient has had long-standing instability, and you can see a lot of muscle atrophy.
Most of these folks are dysplastic dwarfs.
And generally not Olympic athletes. Okay, now another thing that you can get, which is kind of a little bit on a different location, here's a different disease category. Here we can see a patient, the glenoid looks reasonably good. There's a lot of signal. It's hard to really see the details of the labrum here. Everything is low in signal intensity. On the T1 weighted image, another reason why I still like to do T1 weighted images or non-fat suppressed images in the axial plane, we can actually see that this low signal intensity here is actually ossification of the bone, and that's actually a big fatty ossicle, and in reality there's almost no labrum left. This is really ossification of the labrum, and you really just with the fat suppressed, you really wouldn't see that. And this is relatively common in older individuals, and is an indication that you really have significant degenerative disease within the shoulder. And by making that diagnosis, you may be less inclined to be aggressive in a surgical standpoint in these individuals. So just be aware of ossification of the labrum as a indicator of degenerative disease. It shows severe ossification of the inferior labrum as well in the same patient.
Dr. Cruz?
Yes.
Oh, we were all having trouble hearing you that went into static, so I just reconnected. I'm
Okay.
not sure if the other guys did. I can hear you now. I just, it cut out for a slide or two.
Sounds like technology strikes again.
Yeah, I think
So,
they just have,
okay.
I'll just put in the chat that they should get.
Thanks.
log off and log back on.
Thanks. So here's just a case on a CT scan of ossification of the anterior labrum. And here's a little inferior ossification that's actually fractured a little bit in this individual who's in the labrum. Okay, let's just see how many of the group is still with us here. Okay. So Aram, are you with us?
He said before he doesn't have a microphone, so he can hear us, but we can't hear
Okay.
him.
Sean, you're with us?
Yes, I'm still here.
Yuri,
You
you're
did
still
drop
here?
out, but yes, sir.
Okay, great. Okay. So why don't we go on now in the next few minutes to talk about labral tears in general. And we typically divide labral tears into we can divide instability into anterior instability, posterior, inferior, superior, multidirectional instability, and then we can look at complications of instability. With each of those, they tend to have tears in characteristic locations. So when we talk about anterior dislocations, we're also going to talk about tears of the anterior labrum and so forth. Oops. Okay, so let's look first at the anterior abnormalities. Now, you can separate all these or combine them together. I don't really care. And the shoulder surgeons I know don't really care between a Bankart tear and a Perthes tear. But there is important, an ALPSA is an important finding that we'll talk about why, and then we'll talk about GLAD lesions also. So let's talk about it now. Anterior instability, you typically have an anterior displacement of the humeral head with respect to the glenoid. When the anterior head goes forward, you tend to get a reactive contraction of the muscles, which pull the humeral head back, causing the posterior aspect of the greater tuberosity to impact against the anterior lip of the glenoid, producing typically an impaction fracture in the posterior aspect of the greater tuberosity, which we all know as a Hill-Sachs impaction fracture. Depending upon the nature of the way in which the dislocation occurs, at that time you can also get a fracture of the anterior inferior glenoid, which we'll talk about. Now with this, you can get a Bankart lesion, and a classic Bankart lesion would be an anterior inferior displaced labral tear with a rupture of the labrum's periosteal attachment. That's a classic Bankart lesion. But we'll talk about some other lesions there as well, and talk a little bit about how you go about repairing them. So this is the typical mechanism, first described in 1861, and then later by Hill-Sachs in the radiology area. It's the typical, there's the impaction, the Hill-Sachs impaction on the greater tuberosity. This is what it looks like on plain films, and there you can see the anterior glenoid impacting the humeral head, producing the classic triangular shaped Hill-Sachs impaction injury. And here we can see in the AP view. Here's a CT showing the same sort of thing. And this shows something that we'll talk about in a little bit, and that's a thing called an engaging Hill-Sachs lesion. If the Hill-Sachs impaction fracture is large enough, then with normal motion of the shoulder, you can get the glenoid, portion of the glenoid, to fall into the defect of the Hill-Sachs lesion, and that can produce a lot more mechanical problems in the shoulder. And sometimes may have to be repaired by bone grafting in that location. That's called an engaging Hill-Sachs.
Yuri, is this chronic or acute?
I think that this is a chronic, probably a chronic lesion. But Hill-Sachs is an acute lesion, but I think the engaging Hill-Sachs is probably a chronic lesion.
You're right.
Yeah, in this particular location, you can see that the bone in the defect is corticated. That means it's been there for a long time. If it were an acute fracture, you wouldn't have that nice, smooth, corticated component there.
And that's also from Korea.
Yeah, Dr. Sue. That's right. Okay, and here also from Dr. Sue's, the same an MR scan on that particular patient, where again we can see the dislocated humeral head with an engagement between the glenoid and the Hill-Sachs impaction fracture, and a lot of fluid in the area. And then here we can see the coronal images showing the dislocation and the impaction and some bone edema associated with it. So that's an engaging Hill-Sachs lesion. Here's just some, now one thing I want to point out here is you can dislocate in many different directions. And the exact location of the bone injuries are going to depend upon the real direction and the position of rotation of the humeral head at the time that it occurs. So expect some variations in exactly where these lesions are, and you can get we won't talk about all the I don't think we're going to talk about all the dislocations. There are some very unusual ones which are more inferior with the humeral head in different locations. Obviously, what you always have to look for if it's acute, and this is an indication of an acute one because we can actually see the fragments here which are corticated on one side and not on the other side, and lack of cortication deep to this. So this is more of an acute injury in this particular case. And then here we can see this is a very large Hill-Sachs impaction injury. There's some size measurements that people like to use. This would be at risk for later being an engaging type lesion. So, Susie, what do you think's happening here?
Well, on the far left side, I don't even see the humeral head. So it's sublux, or dislocated, sorry, it's dislocated. And on that side, you don't see the glenoid, so it's dislocated. There's abnormal signal intensity within the superior, where your arrow is. And so, here we have another engaging lesion. And then I wonder if there's a lot of scar tissue or fluid.
So this is one that was more of an acute dislocator, and then it was fixed. And for some reason, they did an MR scan before they relocated the shoulder. John, do you want to talk a little bit about shoulder relocation?
Well, this would have to be not an acute situation. I don't think you're going to get somebody into an MR scanner with this condition, unless you knock them out with IV drugs or whatever. Anyway, reductions are easy. All you have to do is relax the patient. Give them IV morphine, IV Valium, and usually a gentle pull, and or put the patient in a prone position and put the arm over the side of the stretcher, and then the arm will go back in place. You can go have a cup of coffee and put the 5-pound weight on it, and when you come back, usually it's reduced. And the patient is very happy because they feel no pain.
Yeah, in the early days of MR, one of the indications for MR was if you had difficulty in the relocation, and there were some reports of cases that were difficult if the biceps tendon dislocates, as this has, it can actually be a restriction for having complete relocation of the shoulder, and you can see that nicely with MR. But that's a very small percentage of anterior dislocations. Yeah.
What is that tissue that you see right in front of the glenoid there? Is that fluid or is that like scar tissue? What is that?
Yes.
No, a little bit further. No, other way. Down. There you go, all that stuff.
That's joint effusion.
That is joint effusion.
Yeah. This is a low field scanner.
I did have a patient once. It was an unusual case. It was a 70-year-old female, and she fell and had a dislocation for the first time. And my usual tricks didn't work on this gal. And the only patient I ever had, and I had many dislocated shoulders that I've treated. I had to take her to the operating room, and all she needed was a little more IV drugs, and she started to snore a little bit, and the shoulder went back in.
So here's just the sagittal image showing the dislocation of the humeral head, anterior dislocation. So this is what an acute Hill-Sachs lesion looks like. On the PD fat images, when it's acute, you get bone marrow edema adjacent to it. It's a typical V-shaped configuration. We've seen why when we've looked at the CTs and the MRs and the plane films in the dislocated position. This is on a gradient echo image where you can see the morphology. typical morphology. This is acute Hill-Sachs. We don't need to see this. More examples and size. So when you see this, it's important to recognize the edema. You look to see if there are any more broad fractures, like in this particular case associated with it. You need to look for fracture fragments and so forth. Occasionally you may need to recommend a CT scan. Make sure that there are no focal defects in the deltoid associated with it, and that there's nothing in the joint space that could inhibit relocation if you happen to scan when they're dislocated, but that's very rare that you would ever want to scan with dislocation. This is someone who had trouble, and that happens to be a biceps tendon that dislocated there. This is from Brazil. So this is the biceps tendon that was inhibiting relocation, but that's very uncommon, but just be aware of it. And here's the biceps tendon coming up between the humeral head and the glenoid, as in the early papers. Okay, here's a 30-year-old male with pain and clicking on an abduction to 90 degrees after surgical reconstruction and a dislocation case. And here, these really aren't the best images. This is someone who actually had an engagement. So Olympus Vasti likes to have a certain checklist that he thinks people should go through, and Or is the team doctor for the Ducks here, used to be for the Angels, and this is from a lecture that he gives at the course in Vegas every year. So you really need to look at the osseous structures that we've already talked about, looking at any deficiencies, the version angle if it's abnormal, look for the humerus for any fractures, and then you need to look for chondral injuries when you have dislocations. Also evaluate the labrum for any labral tears. So we've already seen acute Hill-Sachs. This happens to be someone who had this patient had a history of dislocations and now had another dislocation. What we can see here's the Hill-Sachs lesion. There's some marrow edema here, which would go along with a more recent injury. And then if we look down here, we can see a very abnormal labrum. And that if you have an acute single event, the labral tear you usually get is you see a kind of almost normal morphology of the labrum. It's just knocked off with fluid going deep to the labrum where it's been separated from the glenoid, with or without a periosteal attachment, as we'll talk about in a minute. This is a characteristic finding that you can see in a chronic lesion that's been around a long time. And what happens is this is fibrous reaction trying to heal the dislocation. And there are two things that you have to look out for here. One is if you have the labrum here, which is knocked anteriorly, then it can adhere down to the anterior periosteum, and that can be a problem. Or you can have it torn off with the periosteal attachment, which is called a Perthes lesion. And we'll talk about both of those in a minute and why it's important to at least recognize the first of those. But this is a chronic anterior labral tear. Hill-Sachs lesion, and here we can see a displaced labrum where it's been knocked off its attachment and now is unstable anteriorly. This one has a very abnormal, more degenerative morphology to it, which probably also means that this is a chronic subluxar that's had a chronic tear. Here,
Correction, a recurrent subluxar. What would you rather have, Sheila? A patient, in terms of good results, a patient that's a young patient or an older patient with a dislocated shoulder?
first time?
First time, yeah.
First time, I would say a young patient.
Upside down, kiddo.
Oh no.
Older patients not having a dislocation earlier means that their shoulders were normal, and it took a significant trauma to produce them. A younger patient, usually that means that there's some kind of an anatomical situation that probably predisposes them to dislocation. And the treatment, an older patient, you put them in a sling for 6 weeks, you almost never get a recurrence. In younger patient, it's 50%.
Okay, well, why don't we stop here and we'll start in at this slide tomorrow, okay?
Thank you.
Thank you. Yep.
Thank you.
Thank you.
Yeah.